Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Arun Srivatsa. Dr. Srivatsa is a gastroenterologist.
All right, so most of us have experienced abdominal pain at some point or the other. And most of you have also experienced bloating, constipation, or the occasional discomfort. So we'll talk more today about symptoms that your digestive system can produce when you're feeling sick. And we'll talk about some common conditions, and we'll tell you more about how to improve your digestive health. So these are some of the conditions we'll talk about today. We'll talk briefly about celiac disease, diverticulosis, irritable bowel syndrome, and various other conditions. So the most common symptom you can have from your digestive system when it's feeling sick is abdominal pain. So it's pain anywhere between your ribs and your pelvic bone. It could be in the center, it could be to the right, to the left. And what's interesting is each specific area is usually associated with some specific conditions or diseases. So we'll talk a little bit more about each specific area that you can have abdominal pain in. So let's start with epigastric pain. This is pain right in the center of your abdomen and more towards where your ribs meet, right in the middle. Most commonly, pain in this area is thought to be from peptic ulcer disease, so what people call an ulcer. So that's usually a disease affecting the stomach or the small intestine right after the stomach. You could also have pain in this area when you're suffering from gastritis or an excess of acid production, also known as acid reflux. You could also have pain referred to this area from other organs such as the heart or blood vessels such as an aneurysm. So a heart attack can present in this area. The pancreas is another organ that kind of lives in this area, so you might have pancreatitis or a gallbladder issue that's causing inflammation of the pancreas. So again, this is pain right in the center of your belly. Moving slightly to the right side, the region right below your ribs on the right-hand side is known as the right upper quadrant. And pain here can be usually a symptom of gallbladder disease. Inflammation of the gallbladder is known as cholecystitis, and chronic diseases of the gallbladder are called biliary colic. So if someone says they're having a gallbladder attack, usually this is where the pain is located. Again, the liver is another organ right next to the gallbladder. So if you're having an inflammation or a viral infection of your liver called hepatitis, or maybe a liver abscess, you could have pain in this area. The liver can also get enlarged when you have heart failure. So sometimes diseases of the heart can actually produce pain over your liver area on the right side. Certain other rare conditions like herpes zoster, again, a heart attack involving the right side of your heart, or an ulcer can also cause pain in this area. The lung sits right above this region, so an infection of the right side of your lung, especially the lower parts. So if you have a right-sided pneumonia, you can have pain actually in the right side of your abdomen. So let's move now to the left side, the exact mirror image of what we just talked about. So on the left side, right below your ribs, on the left side, the organs here, the number one organ here is the spleen. So if you have diseases of the spleen like splenic enlargement or a rupture, you could have pain in this area. Again, inflammation of the pancreas, because the tail of the pancreas sits in this area, so you could have pancreatitis causing pain on the left side. Similarly, a heart attack of the left side of the heart or an infection of the left lower lobe can cause pain in this area. So we'll move now to the right lower abdomen. So this is right above your pelvis and on the right side of your abdomen. Most commonly, pain in this area is due to appendicitis. That's the number one cause. Disorders of the small intestine close to this area called Crohn's disease or a small bowel obstruction can also cause pain in this area. Leaking blood vessels, diseases of the female parts such as pelvic inflammation or an ovarian cyst or a ruptured ectopic pregnancy can also cause pain in this area. As you go lower down, the kidneys and kidney stones can cause referred pain to this area. And most people with hernias have pain either on the right or left side in this location. The mirror image of this is the left lower quadrant. The most common cause of abdominal pain on the left lower side would be diverticulitis. Again, diseases of the female parts such as ectopic pregnancies, pelvic inflammation, and ovarian cysts can also cause pain in this area. Chronic constipation and left-sided hernias are also important causes of pain in this location. Finally, we'll move to the belly button area known as the periumbilical region of your abdomen. Diseases of the transverse colon, which is your large intestine, can present here. Viral gastroenteritis can start with pain in this area. Most of your small intestine is located in this region, so if you have small bowel diseases, they can cause pain in this location. An important cause would be bowel obstruction, so usually bowel obstruction would cause pain to start in this location. Now, some people don't localize pain. They come in complaining of pain all over their abdomen. So this would be termed as diffuse pain. Diffuse pain can be due to serious conditions, or it could be completely benign. So severe diffuse pain due to serious conditions would be seen in a condition called generalized peritonitis, which means one of the digestive organs is actually ruptured or is very acutely infected and inflamed. And so the whole lining of your abdomen is now painful and inflamed. This can occur, for example, in acute pancreatitis. People with sickle cell disease, where the blood flow can be blocked. This is also known as mesenteric thrombosis. Certain other conditions such as intestinal obstruction or diseases of the blood vessels such as an aneurysm can cause pain like this. Some people with irritable bowel syndrome or psychogenic illnesses can also have diffuse pain. These are various different types of pains we've talked about. Sometimes your doctor may call this referred pain. So referred pain has two meanings. One is an organ outside the abdomen is actually causing pain, but the pain is moving to your abdominal area. So as we talked about, you can have an infection in the lungs, especially the lower lobes, or you could be having a heart attack, and that's involving the lower part or the inferior part of your heart, or you could be having a clot in your lungs. The other type of referred pain would be pain in your abdomen due to one of your digestive organs is now referring pain outside the abdomen. So for example, gallbladder pain can be referred to your shoulders, typically your right shoulder. Pancreatic pain can go to your back. Some ulcers, especially once they perforate, can radiate to your back or to your shoulders. The same way kidney pain can move down to your groin, and certain large intestinal lesions, especially involving the rectum, can actually refer pain all the way to your sacrum. So this is what your physician may call referred pain. Practitioners and physicians also like to describe pain using some technical terms. We call pain visceral when it originates in one of the digestive organs. And you can see the diagram here. The brain receives nerve impulses from the skin as well as the digestive organs. And most of your life, you get more sensation and impulses from your skin. So that the time when your digestive organs or the deep organs, such as your heart, start producing pain, it's a new phenomenon for your brain. So it frequently confuses the location of pain to the skin overlying that organ or the skin that is supplied by the nerves that are also supplying that organ. So this is what is known as referred pain. And this is the reason why you have referred pain. Pain can also be termed as colicky, where the pain comes and goes in waves, where the pain intensifies, lasts a few minutes, and then subsides. So colicky pain is thought to be more digestive in nature. It seems to originate more in a digestive organ. On the other hand, a physician may call this parietal pain, which is usually pain coming from the lining of your abdomen. It's not necessarily from a digestive organ, but the peritoneal lining is inflamed. And this pain is more constant, and it's made worse when you push in. And so this gives the physician some clues as to where exactly your pain is coming from. So we'll talk a little bit more about organic versus functional pain. Organic pain, as the term implies, is starting in a digestive organ. Functional pain is not limited to one organ and is not usually caused by a serious disease. It could be caused by gas cramps, it could be constipation, it could be irritable bowel syndrome. So what distinguishes serious organic pain from functional pain? So starting from the top, a pain that is acute or persistent, started suddenly and is increasing in intensity, more likely to be organic. And moving down that row, it's organic pain is more sharply localized. Usually within a few hours to within a day, the pain becomes localized to that organ. Usually interrupts sleep and usually is not located right at the belly button, usually is a little further away. And usually the patient has some other symptoms such as fever, nausea, vomiting, weight loss. Usually the labs are abnormal, showing either anemia or a high ESR. Functional pain, on the other hand, has been present for a longer period of time, can be present in different locations at different times, usually has no effect on sleep, and usually centers around the umbilicus, the belly button. And the associated symptoms are more vague and non-specific, and sometimes is associated with stress as a trigger factor. So as a patient comes in to see their physician with all these complaints of pain, this is what a physician will like to take in terms of a history from the patient. As a physician, we like to ask you, what is the onset of your symptoms? When did this start? Was it within a few days? Was it several months ago? Or has it been there for several years maybe? And can we describe this pain better? Is it colicky? Is it sharp? Is it present all the time? Does it wax and wane? Does it get worse when someone pushes in on it? Does it go anywhere else? Does it go to your back? Does it go to your shoulders? And what makes it worse? What makes it better? So when a physician examines you for symptoms related to the digestive system, they usually start with inspection, which means looking at your stomach, seeing how it moves when you breathe, seeing if there's any fullness or distension. Then they might listen to your stomach with a stethoscope to see if your bowel sounds are normal, if they're hyperactive, or if they're really sluggish. They might tap on your abdomen, and then finally they'll palpate it, which means press on different parts to see which is the most painful part. They'll also see if you have what's known as guarding, where you resist pushing down. And they'll also see if you have rebound tenderness, which is when you release your hand, the pain actually increases because the peritoneal lining is inflamed. If appropriate, a rectal or pelvic exam might also be indicated. Next step usually is to run urine and blood tests. The blood tests include a hemoglobin, white blood count, liver numbers, kidney numbers, and pancreas numbers. Imaging would be the third step, which would be X-rays in simple cases, ultrasound, CT scan, MRIs, and eventually either an endoscopy or a colonoscopy, depending on the location or the suspected condition. All right, having talked a little bit about all the different types of pain, we'll now move on to different causes of acute severe pain. So when we talk about acute pain, we're talking about pain that started usually within the past week, definitely within the past 2 to 3 weeks. Anything more than 3 weeks ago is termed chronic. So let's start with appendicitis. So appendicitis is the #1 diagnosis when a patient comes in with an acute abdomen. It's the #1 condition we want to rule out. It's the most common surgery performed in the United States, which is an appendectomy. So let's talk a little bit about appendicitis. So it's a disease where the appendix is inflamed, and usually the pain starts right in the right lower quadrant. Sometimes it starts right in the belly button area, but then moves within a few hours to a day to the right lower quadrant, which is the right side of your abdomen, closer to the pelvis. Usually the first symptom is pain. There is associated nausea or vomiting usually present once appendicitis starts. Fever usually is a secondary sign, which usually starts maybe 6 to 12 hours after the pain starts, because the first eliciting problem is something sticks in the wall of the appendix and blocks it, and it starts an inflammatory response followed by an infection 6 to 12 hours later. So when the physician examines you, usually there is a low-grade fever by that point, and there's tenderness on the right lower side, along usually with some rebound and guarding, which can be present by that time. The labs usually show a high white count, and usually the next step at this point is to get a CT scan, or if the index of suspicion is pretty high, they might wheel you right away to surgery. The treatment is usually IV antibiotics and surgery. The next condition we'll talk about is diverticulitis. This again is a pretty common disease, usually a disease of slightly older age. Again, results from stagnation of material, either food material or other material in your large intestine. Usually a single diverticulum is involved. Diverticula are little pockets in your large intestine. They develop with age, or they develop because of lack of fiber in your diet. So when fecal material or food gets stuck in a diverticulum, it results in a blockage, which then causes what's called a pressure necrosis or inflammation of that area. And eventually this leads to a steady colicky pain that gets worse with time, usually in the left lower quadrant of your abdomen. Fever usually starts shortly thereafter. Physical exam shows that the person is tender to palpation on that side. The diagnosis usually can be made right in the office or in the hospital setting, but sometimes we'll run more tests like a blood count and a CT scan to confirm the diagnosis. Treatment for mild cases, sometimes they do resolve spontaneously. Most cases do need antibiotics. Mild to moderate diverticulitis can be treated at home with oral antibiotics. We usually recommend bowel rest, so we say stay on a liquid diet, just enough to maintain hydration. Severe cases will need IV antibiotics, hospital admission, and maybe 2 to 3 days of complete fasting. So here's a picture showing on the left side the pockets as seen on a colonoscopy. So that's known as diverticulosis. But when the pockets get blocked with material, they can get inflamed, and that's diverticulitis. We'll talk now about cholecystitis, or what's known in lay terms as a gallbladder attack. So as you can see in the picture here, there's a normal gallbladder, which kind of looks like a healthy green avocado. And then below that is an inflamed gallbladder, which is angry, red, swollen, and filled with gallstones. So gallbladder attacks or cholecystitis caused by impaction usually with a gallstone. The gallstone usually gets blocked right in the neck of the gallbladder, but sometimes can go further down and block your bile duct. So the pain from a gallbladder attack is, again, as we talked about, it's on the right upper quadrant, can go to your right shoulder, can also go to your back if the stone moves further down into your bile duct. Usually the physical exam shows when the patient is lying down and you push on the right side of their abdomen, they have pain. So it's known as right upper quadrant tenderness. Sometimes you can actually feel the gallbladder that's inflamed if you palpate that area. So the diagnosis would be by checking some labs, such as a white blood count to see if that's elevated. We'd also check liver numbers, because the gallbladder stone sometimes blocks not just the gallbladder, but also the liver tubes, known as the bile duct, and your liver numbers go up. The best imaging would be either an ultrasound or a HIDA scan, which show that the gallbladder is blocked and inflamed. The initial treatment would be admission in moderate to severe cases for IV antibiotics, followed by surgery. So usually surgery is recommended once you have gallstones and a gallbladder attack. We're now going to talk about pancreatitis. So this is an acute inflammation of the pancreas. As you can see in the picture here, there's involvement of the head of the pancreas, which is the big part of the pancreas close to the intestine. The most common cause in the United States would be gallstones or excess alcohol. The pain is steady and usually pretty severe. It usually radiates to your back, sometimes to the left side. There's usually plenty of nausea and vomiting. The patient looks pretty sick, usually needs hospital admission. The physical findings would be sluggish bowel sounds, along with some distension, which is swelling of your abdomen. They may be rebound as the peritoneal lining gets inflamed by the pancreatic enzymes. The upper abdomen may actually start showing some rebound tenderness. The main labs that would be checked would be, again, a white blood count, hemoglobin, pancreas numbers known as the amylase and the lipase. These usually go up in an episode of acute pancreatitis. The treatment would be admission for IV fluids, fasting, and pain control. And then we would then focus on the underlying cause. So usually the cause is either a gallstone or alcohol, and we'd be educating the patient about that. We're now going to talk about another cause of severe acute pain, which is an ulcer, especially an ulcer that's perforated. So that's known as peptic ulcer perforation. So here the photo shows a picture of your stomach with literally a hole in it, and that's what an ulcer is. So it can cause massive bleeding, or it can cause pain, or both. So it's a life-threatening complication of peptic ulcer disease. Perforations are slightly more common in the small intestine than the stomach. There's an important bacteria that can cause peptic ulcer disease that's known as Helicobacter pylori that can be treated with antibiotics before it causes complications such as this. Other known risk factors for peptic ulcers are non-steroidal medicines, in other words, common painkillers such as ibuprofen, Motrin, naproxen, indomethacin, and so on. So a peptic ulcer causes pain that is steady, severe, and usually in the upper part of your abdomen, and it can radiate to the back or to your shoulders. There's usually a history of similar pain, but more mild in nature for the past several months. So one should not ignore pain because it might just be a precursor to a more serious condition such as this. Physical exam shows tenderness to palpation in the upper abdomen, along with muscle rigidity because the stomach has now had a perforation and the stomach acids are pouring into your abdomen, causing inflammation of the lining. So as you can imagine, it's a surgical emergency needing hospital admission. They'd start with an X-ray or a CT scan that would show the perforation and then would take you to surgery. We'll talk now about small bowel obstruction. This is, as the term indicates, a blockage of your small intestine. The way this would present is a sudden onset of crampy abdominal pain, starts over the belly button area and then moves from the umbilical area to steadily all over the abdomen, causing more diffuse pain. Vomiting is usually an early sign because the bowel is blocked. It tries to upchuck all its contents into your stomach and back into your food pipe. There are various causes of bowel obstruction. This image shows 4 common causes. One would be a hernia. The second would be adhesions, where parts of your small intestine are stuck to each other, usually from scarring from prior surgeries. Other causes would be intussusception or a volvulus. A volvulus is where the bowel rotates and creates kind of a knot around itself. And intussusception is where part of your bowel actually inserts itself into the next part and causes a blockage. So the diagnosis, again, mostly with imaging, either an X-ray or a CAT scan. It would be aided to exclude other conditions by doing blood work, such as a hemoglobin, white blood count, and pancreas numbers to make sure it's not something else we're dealing with. Treatment of a bowel obstruction is usually placing an NG tube to suction out the contents of the stomach and the small bowel that are proximal to this lesion and to see if it resolves by itself. But if a day or two of NG suction doesn't help, usually the treatment would then be surgery. We'll talk a little bit about blood vessels causing abdominal pain. So the aorta is a large blood vessel that runs in the center of your abdomen from the heart. That can rupture if it has an aneurysm. And that's not a good condition to have, but it can cause severe abdominal pain, usually associated with smoking and older age. It's a sudden onset of pain and can be felt in the chest or the abdomen. And then rarely, as the tear progresses down the blood vessel, the pain may radiate into your legs. The physical findings, usually the patient is in shock, very low blood pressure, very fast heart rate, and is rapidly deteriorating. Diagnosis is made by a CT angiogram. They'd want to rule out heart attacks and other common conditions that can present like this. Usually the treatment is surgery. Certain disorders that more commonly are seen by gynecologists can cause abdominal pain, and we would refer you to them if that's the case. So common conditions like pelvic inflammation, urinary infection, ovarian cysts. More rare conditions such as ectopic pregnancy and ovarian torsions can cause all abdominal pain in the lower abdomen. So that completes acute abdominal pain. And now we'll move on to more chronic pain, So chronic meaning it's been there usually for more than 3 weeks, usually more than 3 months in most cases. These syndromes are not as serious or fatal as the previously discussed acute syndromes, but nevertheless they can cause a lot of discomfort and affect people's lives, and a lot of people can be troubled by this. And they all have usually good treatment available, so we'll talk a little bit about each of these conditions. So we'll start with irritable bowel syndrome. It's also known as IBS. It's believed to cause pain because of severe abdominal spasms created by usually the muscles in your large intestine. Now, people have muscles in their large intestine to move the fecal material forward. And in IBS, we believe these spasms cause more severe pain. So it's a condition that is classified as functional. It's functional because the organ itself seems to function fine. So if you were to do a colonoscopy or a CT scan, there's nothing structurally abnormal and it seems to do its job just fine. There are also no biochemical abnormalities, which means the blood tests usually are all normal. This condition affects usually young females. It might affect as high as 14 to 25% of females and a slightly lesser percentage of men. Usually starts in late teenage life and continues till the late 30s or early 40s. If someone has not had symptoms like this, if someone hasn't had symptoms like this in their early life, but then now starts having these symptoms in later life, usually that's not IBS, and so we need to be careful about that. So the common symptoms are, on the right-hand side of this picture, we have various symptoms that can occur. We have headache, we have a dry mouth, sensation of a lump in the throat, some trouble swallowing along with some chest pain, nausea, dyspepsia or heartburn. And then quite frequently people complain of bloating, abdominal distension, and maybe even constipation. Sometimes the constipation alternates with diarrhea. There could be, on the left-hand side of the photo, some syndromes associated with this, such as chronic fatigue syndrome, sleep disturbances, PTSD, TMJ syndrome, and fibromyalgia. So the pain in the abdomen is usually non-radiating, meaning it doesn't go anywhere else. It's crampy and usually located in the lower abdomen. Usually is worse after meals, made worse by stress. And one of the most important factors is usually this pain is relieved after a bowel movement. Most people would say that's the case. Usually sleep is not interrupted, and this is a good point to remember in IBS. People usually have had more than 3 months of symptoms, and what do we think causes IBS? Certain factors might predispose to IBS. The psychosocial makeup of the individual, so either social stresses or psychological stresses, prior infections, prior viral gastroenteritis or bacterial infection. They may have altered bowel motility. They may have hormonal imbalances or imbalance of neurotransmitters. They may also have what's known as visceral hypersensitivity, where their organs are just a little more sensitive to pain compared to other individuals. So some of the diagnostic criteria that physicians might use are 2 or more symptoms present 25% of the times, which is altered bowel habits, either more than 3 bowel movements a day or less than 3 bowel movements a week, altered stool form, altered stool passage, passing mucus, or feeling bloated all the time. Some tests one might do for IBS. The main test would be to rule out more serious conditions. So we want to rule out organic disease. So we'd want to rule out celiac disease. We'll talk a little bit more about that. We want to rule out anemia. We want to rule out bleeding, liver abnormalities. So we'd probably start by running a panel of blood work and some stool tests to rule out infections in your intestine. Eventually, people may need a colonoscopy or an endoscopy to make sure there's nothing structurally wrong with the intestine before we label this as IBS. The goals of management would be, number one, to rule out serious conditions as we talked about, and then to help modify the diet or give you medicines that help with your symptoms. So most of the time, we want to make sure that organic disease is ruled out, especially if someone is over the age of 50. The treatment mainly involves diet, such as a FODMAPs diet. We'll talk a little bit more about that. Some people may need fiber supplements. Some people with diarrhea may benefit from antidiarrheal medicines. People with constipation might benefit from medicines such as Amitiza or Linzess. Here's an example of a FODMAPs diet. So FODMAPs stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So it's just an acronym for that. These are all sugars that are present in vegetables and fruits. They may not be sugars to you because you may not find them sweet when you taste them, but the bacteria in your intestine can digest them as sugars. So the bacteria digest these FODMAPs in your diet, and they produce gas which can cause bloating. They can produce waste products that may cause diarrhea. So eliminating FODMAPs from your diet, and there are many FODMAPs diets available online, and there are resources for you to find them. A diet like this might help with IBS. There are some medicines that we can use for IBS. Usually these are antispasmodics that help relieve some of that muscular spasm. For example, dicyclomine or hyoscyamine would be medicines we would use. For people with a high level of stress and anxiety that overlays IBS, we can use anti-anxiety medicines which function as gastrointestinal neuromodulators such as amitriptyline or nortriptyline. Some people may have bacterial overgrowth that contributes to IBS, and we would use rifaximin as an antibiotic, for example, to treat IBS. We'll talk a little bit about probiotics. There are various probiotics available, as you can see. These are some of the common ones. Probiotics have got a lot of good rap and bad rap over the past few years. The current evidence shows that they may not help as much, and they might harm in some conditions, especially if you're immunosuppressed. The best natural probiotic is yogurt if you're not intolerant to milk products. So right now, the verdict is we don't prescribe probiotics, but if you're already on probiotics and it doesn't seem to be harming you, it's probably okay. So we'll now talk about a condition known as celiac disease, which many of you probably know a little bit about. So it's a disorder where you're essentially allergic to gluten, where the ingestion of gluten starts an autoimmune reaction and damages your small intestine. It seems to be pretty common. It's about 1% of people worldwide. We believe at least 2.5 million people in the US are at risk for celiac. So gluten is basically just a protein that's found in some food products or grains such as wheat, rye, and barley. It's what makes wheat dough sticky. So it's that substance that keeps dough from falling apart. And when people with celiac disease consume gluten, the body mounts an autoimmune response to the gluten itself. And therefore, because the gluten is being absorbed in the small intestine, that's where usually the attack happens. So what essentially happens is the villi, which are these finger-like projections that help absorb nutrients, these villi start getting damaged and blunted in celiac disease. So as a result of that, as you can imagine, you're not absorbing all the nutrients that you need. So you can have a host of conditions. It may present in mild cases just as nutrient or vitamin deficiencies, vitamin D deficiency or osteoporosis, or vitamin B12 deficiency or iron deficiency causing anemia. In even more milder cases, it may just cause irritable bowel syndrome because you just feel like your intestines are just chronically spasming or inflamed. It can also cause gas, bloating, diarrhea, may rarely even cause constipation. In more serious conditions, chronic vitamin malabsorption can damage your nerves and cause central and peripheral nervous system issues, including a wobbly gait, neuropathy, myopathy. It can damage your pancreas, causing pancreatic insufficiency. It can also cause gallstones. It's been linked to almost every organ in your body. So it can cause infertility, it can cause or be associated with type 1 diabetes. It's also found more commonly in people with Down syndrome. So really it's an important disease to be aware of, and it's easily tested. The test for celiac disease is a simple blood test, and we'll talk about it in a little while. Chronic celiac disease has its own complications because of long-standing inflammation. And this can it can give rise to cancer. So you can have either a non-Hodgkin's lymphoma or actual small intestinal carcinoma. Rare cases of esophageal cancer and thyroid cancer have also been described. So as we talked about, a blood test can be used to diagnose this. There's an antibody for gluten that can be checked in your blood. It's a simple test. We can also do genetic testing for celiac disease. In other cases, you can do an endoscopy where you take a biopsy from the small intestine and see if there's damage to the villi. And that's a more specific test to see if you have celiac disease as well. The mainstay of management is to stay away from gluten. Sometimes easier said than done because gluten is found in a variety of foods. It's found in canned foods, frozen dinners. Most restaurants may or may not have a gluten-free diet or a gluten-free menu available. But even small amounts of gluten, like crumbs from a cutting board or toaster, can elicit an immune response in people with celiac disease. So it's important to be completely gluten-free if you're celiac. The other part of treatment would be to supplement your diet with vitamin and minerals, such as calcium. People would need regular monitoring for bone density and as well as their antibody levels to make sure the antibodies are not going up. If your antibodies go up in celiac disease, usually that means you're being exposed to gluten in some way or form. It's also important to screen family members because they have a higher incidence if this is a genetic cause of celiac. We're going to now talk about constipation. So again, a very common condition. Almost everyone has experienced this once or more times in their lives. It's in fact the most common digestive complaint, and it's defined as either a lumpy or hard to pass stool by most people. Physicians would say less than 3 bowel movements a week could constitute constipation. Some people would also use a sense of incomplete evacuation as defining constipation. Most people would also have straining as part of it. There's many potential underlying conditions that can cause constipation. There's neurogenic disorders. Diabetes can damage your nerves and cause constipation. Other neuropathies, Hirschsprung's disease and Chagas disease are rare causes. Multiple sclerosis and people with Parkinson's are again at risk. Endocrine disorders such as diseases of your thyroid can cause this. Most people who are pregnant, just because of the baby pushing down on the colon, can be constipated. Various medicines can cause this. Some antihistaminics, antispasmodics, most narcotics can cause constipation. What comes as a surprise to people is most blood pressure medicines, especially calcium channel blockers, can cause constipation. People who take iron supplements and antacids can also feel constipated. When is constipation a danger sign or symptom. When constipation is associated with bleeding, anemia, weight loss, or in someone with a family history of cancer, constipation could be the first danger sign. So in all those cases, we would recommend a colonoscopy, just to make sure nothing else is causing a blockage that's worsening your constipation. The first step to treat constipation would be a fiber supplement. A high fiber diet, such as increasing your vegetables or fruits, would be enough for most people. But sometimes you need a fiber supplement to add to that, and these are some common fiber supplements that are available over the counter. Stool softeners such as Docusate or Colace would be the second step. These medicines actually have a surfactant or soap-like action, and they help soften your stool. The third step would be laxatives. Now again, in laxatives, there's several over-the-counter laxatives, such as Miralax, mag citrate, milk of magnesia. And then there are prescription strength laxatives such as Linzess or Amitiza, which would be used for more severe cases of constipation. So we're now going to talk about diverticulosis. We talked a little bit about this before. Again, these are pockets in your large intestine. And this seems to be a condition that is becoming more prevalent as civilization gets more modernized. It seems to occur later in life, and as I said, about 50% of people around the age of 50 seem to start getting diverticulosis around that time. Most people with diverticulosis can have no symptoms at all, but a lot of them start getting irregular bowel habits where their bowels get more thin and ribbon-like. They may have abdominal pain on the left side. They may have bloating or gas. It may mimic irritable bowel syndrome only at a later age. If one does a CT scan, you can actually see the pockets on a CAT scan. One could also do a blood count or a stool test to look for other evidence of diverticulosis or diverticulitis. And the treatment would be, again, to increase fiber, like we talked about. There was a prior recommendation to avoid popcorn, nuts, and seeds, which is not entirely approved anymore by the societies. But in my personal experience, a lot of people do find benefit or improvement in their symptoms when they do so. So it's good to increase fiber from vegetables, and if you feel that popcorn and nuts seem to aggravate symptoms, it's a good idea to go ahead and eliminate or reduce them. Now we'll talk a little bit about acid reflux or GERD. So GERD is gastroesophageal reflux. It occurs when stomach acid or stomach contents move from your stomach into your food pipe. And usually it creates a bitter or acidic taste in your mouth. It can affect your food pipe or your windpipe or your lungs. It can even trigger an asthma attack or a case of laryngitis. A lot of people use antacids, and most of them may not even be aware they have acid reflux disease. So heartburn is the most common symptom. It doesn't really correlate with damage. So people can have severe heartburn or no heartburn, and they can have reflux esophagitis, or they may actually have minimal esophagitis. Usually symptoms are worse after large meals or meals that are acidic with a lot of vinegar or tomato-based sauces or chocolates. When do we need to worry about acid reflux? The danger signs here are trouble swallowing or a sensation of food sticking in your food pipe, painful acid reflux with chest pain or spasms in your food pipe. When acid reflux coexists with certain high-risk behaviors such as smoking or consuming alcohol, or when you're taking painkillers like what we talked about, non-steroidals, like aspirin, Advil, and ibuprofen. So the mainstay of managing acid reflux is to rule out serious underlying conditions such as Barrett's esophagus, cancer of the food pipe, and peptic ulcer disease. So we'd start off with some antacids. We can run a breath test for a bacteria, but we'd proceed with an endoscopy if there's more severe or atypical symptoms. During an endoscopy, we can examine for ulcer disease, we can examine for bacteria, and for precancerous conditions. Management of acid reflux is quite well known. Eat smaller meals, avoid alcohol and smoking, light exercise or moving around after you eat, maintaining a healthy weight, especially if you're overweight, and using loose-fitting clothes, not tightening your belt too much after you eat, all will help. We ask people to avoid NSAIDs, and most of these foods that aggravate acid reflux, such as chocolates, coffee, tea, and sodas, as well as citrus and vinegar and tomato-based pastes. Medicines for acid reflux, as I said, common antacids can be used. This is a picture of various antacids that are available over the counter. The next step would be H2 receptor blockers. H2 receptor blockers are Zantac, for example, Tagamet, ranitidine, famotidine, Pepcid. One can use these safely for an extended period of time. If antacids and H2 blockers fail, then we move to proton pump inhibitors, which are a little stronger. Some of them are available over the counter, and some of them are prescription. Usually we treat for about 4 to 8 weeks, and then we taper off. Proton pump inhibitors, also known as PPIs, have been associated with a host of side effects. It's important to know about these. The FDA has issued warnings regarding fracture risk, risk of C. diff, B12 deficiencies, kidney damage, dementia. There's a lot of press about these. These are rare side effects and are associated with long-term use, usually more than 5 years or 10 years of taking a medicine daily. So most people are not on these medicines for that long. This is a list of the medicines in the table. So this includes Dexilant, Nexium, Prilosec, Protonix, Prevacid. It's also important to note that these medicines can interact with other medicines. So especially in the elderly, if you're over the age of 65 or over the age of 80, you're on a bunch of medicines and drug interactions become important. The next progression of acid reflux would be peptic ulcer disease, as we've talked before. So it can present acutely with a perforation, but most people don't progress to that point. Most people have chronic pain that can happen with peptic ulcers. And in the elderly, bleeding is more common than perforation because usually you're on blood thinners because of associated heart conditions. And then because of that, you can bleed when you have acid-related damage in your stomach. The other thing that can contribute to peptic ulcer bleeding would be H. pylori, which is a bacteria that can live in your stomach. So here are some risk factors again for ulcer-related bleeding. Most of that focuses on cigarettes, alcohol, but also stress, emphysema, and Advil and Motrin use can contribute to this. Here's a picture showing Helicobacter pylori causing damage to your stomach and predisposing to ulcer-related disease. H. pylori rarely can also cause gastric cancer, so it's a good thing to check for and to treat with antibiotics. So some common symptoms of ulcers would be pain, especially pain occurring when your stomach is empty and which is relieved by eating something or by drinking milk. This pain usually is associated with a duodenal ulcer. A gastric ulcer, sometimes the pain is actually brought on by eating something spicy. So most of these ulcer-related pain can be relieved by taking antacids. So that's a clue when you start having pain and it starts getting relieved by antacids, you should probably get checked for an ulcer. The diagnosis of an ulcer would be by an endoscopy, where we put a thin camera down your mouth when you're asleep. And here you can see the endoscope looking at an ulcer in the intestine. And that's how an ulcer looks in the inset shown. Treatment, again, would be to stop offending medicines and to treat bacteria if present, and to treat either with an H2 blocker or with a PPI. An endoscopy is also useful for bleeding ulcers because we can directly visualize the bleeding and clip it or cauterize or inject it. So now we're moving on to inflammatory bowel disease, or IBD. So there's two conditions mainly that comprise inflammatory bowel disease. One is Crohn's disease, and the other is ulcerative colitis. They both are classified as inflammatory bowel disease. So this is a condition where the intestines, usually the large intestine, but sometimes also the small intestine, is inflamed, ulcerated, and eventually leads to scarring. So on the left side, you see a picture of a normal colon during a colonoscopy, and on the right side, you can see a red, inflamed, edematous large intestine. So ulcerative colitis is one of these conditions, and usually it starts right in the rectum and progresses upwards. Inflammation usually starts in a continuous fashion, as opposed to Crohn's disease, which is more patchy and can involve the entire small intestine or large intestine, and it doesn't need to start in one place. And it can involve different spots during different points or different times during the patient's lifespan. So here's another picture showing the difference between Crohn's disease on the left and ulcerative colitis on the right. This condition, or these conditions, are more common in younger people. More females may have Crohn's disease and more males may have ulcerative colitis. Usually the diagnosis is made in the early teenage or early 20s. Here's a schematic of different symptoms people may have with IBD. It may be a generalized symptom complex with even inflammation in your eyes, jaundice, mouth sores. But most commonly, the symptoms are diarrhea, weight loss, and bleeding. And this is associated usually with diffuse abdominal pain. So here's another schematic of various conditions that can occur throughout the body, because it's thought to be an autoimmune condition which affects the intestines, but the autoimmune phenomena can escape the intestine and affect the rest of the body as well. So you could have joint pains, mouth sores, inflammation in your eyes, you could have kidney stones, you could have a skin rash as part of IBD. The diagnosis of inflammatory bowel disease is usually with a colonoscopy, but we would rule out other conditions such as stool infections and other blood conditions by doing blood tests and stool tests first. When we do a colonoscopy, we would take biopsies in the insides of your intestine to make sure we get tissue for sampling to see, is this Crohn's disease or ulcerative colitis? The management of IBD is usually by a gastroenterologist in conjunction with your primary physician. And there's several medicines that can be used. This pyramid shows a step up versus a step down approach. Most people start with a sulfasalazine or a mesalamine based compound and step up to either prednisone, which is a steroid, or other immunomodulators such as azathioprine, and eventually progress to Remicade. But there's a step-down approach where one could start with Remicade for more moderate to severe cases. We're going to talk a little bit about chronic pancreatitis before we wrap up our talk. So chronic pancreatitis, again, the most common cause is alcohol, especially in the United States. Some conditions could be genetic, such as cystic fibrosis or other hereditary causes of pancreatitis. Pancreatic cancer can also occur in people with chronic inflammation of the pancreas. Pain may be in the pit of your stomach and may radiate to your back, may be also associated with diarrhea and malabsorption because the pancreas is an important digestive organ. And when it's affected, you stop digesting meat and fats. The diagnosis of chronic pancreatitis is usually made on a CT scan where you can see calcium deposits in your pancreas. It can also be made with blood tests and stool tests that show low levels of your pancreas enzymes and malabsorption. The management of this condition is usually by pancreatic enzyme supplementation, and then we're going to treat other coexisting pancreatic dysfunctions such as diabetes that might be present. And we screen for pancreatic cancer, which is a risk of developing in this condition. All right, so at this point, we'll conclude that digestive health is an important and integral facet of your life. Digestive complaints can be minor and common and due to benign conditions, or they may be acute or more serious and can be potentially fatal. So we don't want you to ignore your digestive health. We want you to talk about it to your primary physicians, see a gastroenterologist if need be.